Great. So I'm very honored to present on the Falls and Falls with Injury project and talk to you about a tool that we have available to hospitals. So before I go into our Falls work and our tool, I wanted to just give you some background on the Center for Transforming Healthcare and how we work developing solutions for specific focus areas. Knowing that in healthcare we often fail at things as basic and important as hand hygiene, we recognize as an industry that we are not highly reliable. We all know that other industries such as aviation, nuclear power, and even amusement parks have done a remarkable job of preventing harmful situations and disasters. So we have a lot to learn from them, and that's what we've been doing these past 8 years. And the center was really created in 2008 to transform healthcare into a high reliability industry. The model we work from leading us to high reliability includes leadership, which is a commitment from leadership to zero patient harm, safety culture, which empowers staff to speak up, and robust process improvement, which is a systematic data-driven approach to complex problem solving. We're going to focus much of our discussions today as we talk about our Falls project on that last component, robust process improvement, which is really a key component in the work that the center actually does. The Joint Commission Center for Transforming Healthcare and its participating organizations used robust process improvement, and this is actually a term that we coined here at the Joint Commission. And it's really a blended approach that includes the methodologies, concepts, and tools of Lean, Six Sigma, and change management. This blended approach really helps the center and participating organizations really to address healthcare's toughest safety and quality problems. This approach is very appealing to physicians and other clinicians because it's very data-driven. Complex problems really require sophisticated problem-solving methodologies like robust process improvement. One of the important advantages of employing such process improvement methodology and tools, such as DMAIC, which stands for Define, Measure, Analyze, Improve, and Control, is that they provide a systematic approach to solving these complex problems. Specifically, they really guide improvement teams to examine why processes fail to achieve their desired results. And it is really a systematic search for the causes of then those quality and safety problems and the assessments of the relative contribution of each of those causes that give these improvement tools a great deal of their effectiveness. Once the causes are actually identified, solutions then are targeted to those specific causes and are implemented and validated. Once validated and in the control phase, this is where then the measures are put in place to monitor the process going forward in order really to sustain those improvements over time. But coming up with a great solution will not get you nowhere if you do not consider the impact of change on the people within the organization. We talk often with organizations about process improvement projects, and one of the things that we always hear is, we see improvements made within our organization, but we just can't sustain them. And then we keep on repeating those same initiatives, whether it's every 12 to 18 months later or every 2 to 3 years later. So how can we really sustain those improvements? And that's really the critical piece of the change management aspect of it. So our model for change management here at the Center for Transforming Healthcare is really critical to understand the key stakeholders and really the potential barriers to implementation and, more importantly, to sustainability. So we use the facilitating change model, and this is really an overarching model which includes planning, inspiring the people that are going to work on that project, launching the initiative, and then also supporting the change. And it really isn't a linear model. You're going to be going in and out of these different steps, components, as you go through the life of a project. For instance, you could have people on board at the beginning of a project because they really want to fix something. They understand it's a problem. But then once you start to get into improve and you start implementing those solutions, those same supporters at the beginning now could be your biggest resistors. Because all of a sudden now there's change occurring in their daily process. And we know as humans,
Yeah.
we have sometimes a very hard time with change itself. So there are specific tools to really guide you through each of these steps in the overall tool that we have that we're going to talk about in the upcoming slides. And these tools are really embedded as far as really being able to get that support and commitment throughout the life of a project, and even beyond that as you talk about sustaining those improvements. This is a list of the 27 participating hospitals and health systems that have worked with the center on our project work. Everything from Cedars-Sinai on the West Coast to Texas Health Resources and Baylor in the South to on the East Coast. We have organizations like Johns Hopkins and North Shore LIJ. Now, one thing I did want to mention, we usually have about 5 to 10 organizations working with us on a project. The one thing that all these organizations have in common is that they have the experience and skill set in robust process improvement. The center and the participating organizations have worked on 11 different focus areas that include hand hygiene, handoff communications, preventing falls, which we'll talk about in a second, to our 2 most recent projects, reducing C. difficile infections and preventing venous thromboembolism, which we have collaborated with the CDC. So let's talk about our Preventing Falls project. This was one of the projects that the center worked on. Early on, it was our 5th project, and organizations really struggled with their falls within their organization. So despite long-term and widespread attention to fall prevention among our healthcare organizations, patients continue to fall, and many of these falls result in injury. Hundreds of thousands of patients fall in healthcare facilities every year, and many of these falls result in moderate to severe injuries. These injuries can prolong hospital stays and require the patient to undergo additional treatment. Between 30 and 35% of patients who fall sustain an injury, and each of those injuries on average add about 6.3 days to the hospital stay, as well as cost about $14,000 per fall. Falls has also been identified by the Centers for Medicare and Medicaid, CMS, as an event that is preventable and should never occur. CMS has also identified falls and trauma on the list of hospital-acquired conditions for which reimbursement will be limited, specifically for falls that result in fractures, dislocations, and intracranial injuries. Three key findings came from the work of the project and the participating organizations on this project. And this is something that we've seen over and over again as well in the other 10 projects that the center has worked on. First, there are many causes to the same problem. So in this case of falls, we identified 30 different causes, contributing factors, including risk assessments not accurate enough, staff involvement within the falls program, and the engagement and education of patients and families. The second is that each of these different causes requires its own targeted solution to be effective. And then finally, the key causes differ from one organization to the next, and even from one unit to the next within a hospital. That's why it's so key to really understand your process and really identify what are your contributing factors. And this was actually made evident here in this table. So here's a list of our contributing factors, causes for falls. Each letter across the top represents one of the participating hospitals. An X means that the contributing factor was found to be statistically significant within that facility. So let's take, for example, Hospital A and Hospital C. If Hospital A did nothing, but really heard a presentation or saw some literature from the success Hospital C had with their falls project in terms of making improvements, and then implemented those solutions, as you can see here, they would have only addressed 50% of the actual contributing factors that they had. You also see that they would be implementing solutions to problems that they didn't even have. And what we've seen, this sometimes could be very detrimental, because now you might actually be breaking a process or breaking a step within that process that was actually not broken to begin with. You were having success in that area. Then on top of it, you can see that there are several causes, contributing factors that would not be addressed. So although best practices can be very helpful, sometimes they might not get you to the improvements that you're looking for, because those best practices were created to address a specific contributing factor root cause. And that might not be the same contributing factor and root cause that you have. And that, again, is why it is so critical to really take the time to understand your process and the contributing factors and causes impacting your process, and then developing those targeted solutions to those specific contributing factors, causes you've identified. So targeting solutions to those causes is not just about effectiveness, but also about efficiency. So although one of the hospitals that participated with us on this project had to drop out because they were actually doing reconstruction in that area that they were piloting, the remaining 5 hospitals and health systems, as an aggregate, reduced their rate of falls with injury by 62%, while also reducing their falls rate by 35%. If this approach is translated to a typical 200-bed hospital, the number of patients injured in a fall could be reduced from about 117 injuries to about 45, and avoiding approximately $1 million in costs. Similarly, a 400-bed hospital could reduce falls with injury by 133 patients and expect to avoid approximately $1.9 million in costs. The work of the center and the participating organizations was published by the American Hospital Association on their website in October of 2016. So again, that's all fine and good, but how do we now share all that information with our accredited hospitals and health systems and healthcare organizations? So the outcome of the work of the participating hospitals and health systems for preventing falls, and the way we share the work of the centers through what we call the Targeted Solutions Tool, or TST for short. Currently, we have 4 Targeted Solutions tools available. We have one for hand hygiene, safe surgery, hand-off communication, and preventing falls. For 2017, we are looking into developing a Targeted Solutions tool for reducing sepsis mortality. The tool itself is a web-based application. It's secure and it's part of our accreditation tools that we have available. So it's on your secure extranet site. It's available to all our accredited customers. It's free of charge, so there is no added cost. If organizations that are not accredited by the Joint Commission would like to use the tool, we do have a small fee for that because, again, currently it is on our platform as part of some of the other accreditation tools that are available for our organizations. There's no special training that's required. You don't need to have a Lean Six Sigma green belt or black belt. The tool itself takes you through that step-by-step systematic approach, and you really target your solutions to only the causes that you actually identify. So again, not only being effective with your solution, but more importantly also being efficient. And as you can see, these were the 4 tools that have been available to our accredited organizations, with the first one coming out in 2010, hand hygiene, and our latest one was in 2015, the preventing falls tool. So I kind of want to take you through the tool itself and some of the things that you'll actually see and encounter as you go through the tool. So the Target Solutions tool, again, is that web-based application. It really guides healthcare organizations through a very rigorous step-by-step process following the DMAIC approach of Lean Six Sigma. Again, you'll go through define, measure, analyze, improve, control. You can see that on the tabs at the top as well as in the left-hand field. And you're really going to accurately measure your organization's actual performance. So with each of the tools, there is a measurement tool in there, as well as being able to measure for those contributing factors, root causes. So again, one of the other outcomes or outputs from the tool is that you're going to identify your specific causes to that poor performance you're having with falls and falls with injury. And then once you've identified those causes, those contributing factors, you're going to be directed to those proven solutions that were actually targeted to each of those contributing factors. So again, as I mentioned, the tool is laid out following the DMAIC approach of Lean Six Sigma. And you can hover over any of the tabs at the top. And again, that'll take you through really a step-by-step process, even within that specific section. So as you can see here, we're in section 1.1, so we're in the define phase of the project, and we're right now in the overview itself. So again, you can either get into each of the steps, the phases, by hovering at the top, or you can go into the left-hand bar that's available as well. So when you first start out your project, the Targeted Solutions tool will take you to that first step. So you'll be in that define step in that overview. As you start to work through your project, wherever you have left off, whether you're in measure, analyze, improve, control, that's where the tool actually take you that next time you log in. So one of the nice things about the tool itself is that you'll be able to train data collectors. This is really to ensure that you're going to have an accurate and consistent measurement system. So in the train data collectors, there are downloadable training materials, including, as you can see here, training videos that you can give to each of the data collectors. There's a written exam as well as a test answer key. So at the end of the training session, you want to give out that exam to the data collectors, and this, again, will ensure that the data collection process is going to be accurate and consistent, not just within each of the data collectors, but more importantly, between the data collectors. So if two different people are seeing the same fall and are investigating that same fall, they're going to come to the same conclusion. So the data collectors are expected to score a 90% or better on the exam before they can actually be sent out to collect data. Once the training has been completed, the data collectors are ready then to actually go out and start collecting baseline measurement, which we'll talk about in a second. The other nice thing within the tool, you can actually track your data collectors as far as training and whether or not they actually then pass that exam. So if the data collectors have not passed the exam, again, you can re-educate them with the training video that's provided and then retest them at a later point in time. The goal here is really you want to make sure that any of the data collectors you're sending out are going to be able to give you back accurate and reliable data. So once the data collectors have been trained, they've passed their test, they can then actually start to go out to collect fall data. So in the Add Fall Event section within the tool is where they'll actually start to enter the data collection for each fall event that occurs. And data can actually be entered into the Targeted Solutions tool in one of two ways. The data collectors can get access to the tool directly. So if they're walking around and have an iPad or they're close to a computer, so if you have computers on wheels, they can actually go directly into the tool to fill out the measurement form itself. Or you can actually download the data collection form, print it out, and they can actually collect it manually. And in some date in the future, you're going to have someone that will actually go into the system to actually then add the data collection forms. Now, data collectors will enter responses to the questions asked on the data collection form, and once that has been completed, they will then click on the Save button, and then the analysis can be retrieved both under the Analyze tab as well as the Improve tab once solutions are starting to be implemented. So data is collected both in the baseline period as well as then in the Improve and Sustain period. You can see here we're in the Improve phase because I kind of wanted to show you how that would actually be presented. Here you can see that there is a run chart that presents your baseline data as well as your improved data. So the baseline you'll see is shaded in white. The improved data has like a bluish green in the background. There are ways then that you can actually cut your data. You can either look at all your falls. You can look at your falls with injury. So again, the outcome metric that we are looking at is actually the rate. But you can also, if you want to, you can just look at it by counts as well and see how many number of falls are you having each month. The expectation is that you're going to collect 3 months of baseline and improved data, so we'll be able to validate those improvements. So again, you want to start to see as you implement your solutions, you want to see then the improvement rate go down. If it hasn't, you want to then look at those solutions you've implemented. Have you picked the right solution, 1, and 2, to make sure that the solutions that have been implemented are actually being followed and you have compliance from the staff within that unit, or if you're looking at the project from the hospital standpoint within the hospital. So that's one piece of data that you'll be able to look at. The second piece is, and a real critical piece, is your contributing factors. So we actually have a pie chart that will break down the number of contributing factors. The nice thing is it'll list it from highest to lowest frequency. So again, depending in terms of how many resources you have and how much time you have for implementation, you might not be able to get to all the contributing factors to address them. But again, if you only can address the 3 of them, you're going to address the top 3 that have the greatest impact overall on your falls and fall with injury rates. So again, it's a nice way to prioritize also your solutions. And again, just depending in terms of how much resource you have and how much time you have for implementation, again, a great way to prioritize. So again, you're not going to be working on those root cause contributing factors that really don't have a significant impact on the overall process. Again, thus resulting in not a huge movement in the needle of falls or falls with injury rate. And again, on the left-hand side, you can actually cut your data as well. There are different things that you could look at, whether you want to look at falls by primary cause, falls by injury level, and you can actually look also at falls by location as well. So again, there's a lot within the tool as far as being able to cut that data. The nice thing that I did want to mention about the analysis piece within the Targeted Solutions tool, it's done for you. So once you start entering data into the system, it'll start to do your analysis, both from that outcome metric, which we talked about, the falls and falls with injury rates, but more importantly in identifying what your top contributing factors causes are to why falls are occurring within your organization. Now, once you've identified your contributing factors, then you can start to look at the solutions to implement. And again, you'll look under the Implement Solution section, which you'll actually find 2 different types of solutions. We have our core solutions that you should look at regardless of contributing factors that have been identified, because these were common factors that we saw across the work that we did with organizations, whether it was with the original participating organizations as well as the pilots. So something that you definitely want to look at. And as you can see, one of those core solutions is change management. Because we know now as you start to look at implementing solution, even your greatest supporters at the beginning of the project can now be your biggest resistors. and your biggest barriers. So again, there are a lot of techniques, methodologies, tools that you can use to really get that buy-in and acceptance from staff moving forward. So in our example here, you can see education issues was the #1 contributing factor, and this will actually build off of the final pie chart that you have as you collected data to see what your contributing factors are. So again, you'll see from top to bottom, in order of highest frequency, the contributing factors that were identified as part of your project work. Next to it, then you'll be able to click in to actually view the solution. And as you implement your solutions, you're going to actually be able then to start tracking them, knowing exactly which dates or days you've actually rolled out that solution. So again, it's a nice kind of overall visual board for you to kind of manage your improvement efforts. So once you click on that view solution, you'll see that the solution guide will actually open up. Within that, you'll see the actual problem you're trying to address, so that contributing factor that you identified. You'll also then have the solution itself, what you should be implementing to address that specific contributing factor, but then more importantly, what are the steps that need to be taken to implement that solution fully. So again, you'll have in order that step-by-step process of how to implement the solution, which in this case is the patient and family education contributing factor. The other nice thing with each of the solutions comes an action plan tab. And this is where you can actually look at, and again it aligns with that solution guide, all the steps that are needed to actually implement that solution. And this is where you can develop an action plan that you can actually share with all your staff so they know exactly what's going on as you're moving forward to implement those solutions, where you can assign who's going to be responsible for that particular step for that solution, when that step should be completed. So there's a goal date for implementation, and then when was it actually completed. So, you know, where there's some delays, and you can kind of capture all that. And again, this is not just good information for this project, but might actually be very good information for future projects. If you find yourself implementing some similar things, like, you know, we want to implement something through our IT department, we want to put it in our EMR. Well, the last time we did this, we had some delays because we submitted something, but it wasn't prioritized. So again, it could always help you for future projects. Also, you can see if there were any costs associated for implementation. So if you're buying anything or creating anything as far as resource time, that you want to capture those costs. And then finally, there's also an area for any additional comments that you want to capture as part of the project. So again, this is a great tool that you can display, share with staff, so everyone is aware of the implementation that's going to take place with regards to this project and those solutions that you're implementing. So once the solutions have been implemented and validated, and you've really shown that you've actually made an improvement and not just a change, and again, this is where you can look at the analysis, look at that run chart to make sure that you've seen a shift going down with regards to your falls and falls with injury rates. Then the next piece is, well, how do we sustain it? So you want to really plan for sustainment. And in the control step itself, there are concepts and tools that will be implemented for the process of actually sustaining those gains you have made through this project. So under the control plan section itself, there's actually a control plan template that will be filled out. And again, this is something that you can display then within the unit or within your organization. So again, everybody is aware of what actions need to be taken as part of sustaining those improvements. So without a really thought out control plan, you really run the risk of losing your hard-earned gains. So the plan itself talks about the roles, including who the process owner is going to be, and the responsibilities of that process owner to really make sure that the process is going to be continued as far as monitored and moving forward, as well as if there's anything that trends negatively for that person responsible, that process owner, then to take action. And that's really a key step when we talk about sustainment, is to really being able to monitor the process continuously, to really have that understanding when something starts to deviate or go wrong, to address it right away. I always think of the process owners as kind of investigators. You don't want an investigator to get to the crime scene a year later. It's not going to help. You're not going to know what contributed to that crime. It's very similar to when we talk about process improvement. When something starts to go negative or starting to fail, the quicker you can actually look into it, to investigate it, the easier it is as far as you being able to identify what that contributing factor or cause that is leading to those negative trends is. Again, waiting a year from now, you're going to be doing a project completely over from scratch because so many things have changed. And again, it's very hard then to talk to staff about it because, we do so much work throughout the day. It's very hard to remember a couple hours ago what happened. So again, the sooner you can investigate that, the more critical and more important it will be, and the more successful you will be in sustaining those improvements you've made earlier. So again, this is a great tool to really assign that responsibility and to really lay out the plan of action moving forward to, again, reaching that goal of sustaining those improvements that you have made over time. So again, you're not going to do any rework in the future. So that was kind of an overview of the Targeted Solutions tool itself, going through the different concepts and sections within the tool that are very critical for you to really have a successful project in reducing both your falls and falls with injury rates. I did want to talk a little bit now in terms of the results that we are starting to see. Again, the tool became applicable and accessible to our healthcare organizations late in 2015. So as I mentioned earlier, one of the expectations is to collect 3 months of baseline data as well as 3 months of improved data. The project timeline itself is about 12 months as you go through everything, because again, you're going to have a couple of months time there where you're going to have to implement those solutions, and we know sometimes that'll take a bulk of the project work time itself, is to get everybody trained up to speed and then implementing those solutions moving forward. But we're starting to hear from our healthcare organizations that are using the tool, what results are they achieving from this systematic approach to really understand their process and, more importantly, understand what their contributing factors, causes are. So from one hospital which selected a neurosurgical unit to conduct their Preventing Falls project, they were able actually to reduce their rate of falls with injury by 79%, and their overall falls rate was reduced by 58%. Another organization that let us know in terms of the outcomes that they've seen, they really focused their efforts on a behavioral health unit. And at the end of the project, they had seen reductions of about 66% for their falls with injury rate, and overall falls rate was reduced by 58%. So these are just some of the stories that we're hearing from our healthcare organizations that are using the tool. We are actually here at the Joint Commission in the midst of actually publishing both the work of the original participating organizations as they went through the project, as well as the organizations that were part of the pilot. So just to kind of add on to the work of the center itself, how we work on projects is we'll work with the original participating organizations. And again, one of the things that they all have in common is that knowledge and skill set in the tools of Lean Six Sigma and change management, which we call robust process improvement. Once they go through the project and we've actually been able to validate improvements from that work, we'll take all of those lessons learned, the measurement system, the contributing factors and solutions, and then we actually go through 2 rounds of piloting. The first is with organizations, and we look in particular for organizations that are not skilled in the tools of Lean Six Sigma and change management, because we want to make sure at the end of the day that this web-based application targeted solutions tool can be used by all. Once we validated similar success with the first phase of pilot testing, we'll actually go through a second phase, which will be organizations, again, using different types, whether they have Lean Six Sigma, change management, what we call robust process improvement training or not, will actually then use the targeted solutions tool. So not only will we validate the original work, but most importantly at this point in time, we'll actually validate the tool itself and looking for things of ease of use and everything. So how do you gain access to the targeted solutions tool? There's actually 2 different ways that you can get access. As I mentioned earlier, if you are a Joint Commission accredited healthcare organization, it's already available to you. Your system administrator that handles all the Joint Commission work and the accreditation process within your organization, they have actually access to that extranet where the targeted solutions tool is actually housed and lives. So they can actually give you access to the tool. There's also a second way. You can actually go onto our website, and you'll see that in the upcoming slide, and that'll actually, this whole slide set will be sent to you, so you'll have that information. And it's really www.centerfortransforminghealthcare.org, which you see on the screen right now. That is our website for the Joint Commission Center for Transforming Healthcare. And under the tab Targeted Solutions Tool, when you click on that tab, on the left-hand side, you'll actually see entrance into the TST itself to log on. But unless you have that username and password, you won't be able to get in. So right below it, you can actually request access to the Targeted Solutions tool itself. Basically, it's going to be your first name, your last name, the department you work in. But most importantly, it's going to be your organization email address. Again, it can't be at Yahoo or at Gmail, but has to be your organization email address. That's how we verify it on our end here. And then you'll actually get an email with a username and password, and you'll be able then to log into the Targeted Solutions tool. Your system administrator will also get an email just to alert them that somebody has requested access to the Targeted Solutions tool. So again, as I mentioned, the tool itself is completely confidential. So again, once you go into the tool, that is all your data. That is your organization's Targeted Solutions tool. We have the Preventing Falls tool, and we also have the other 3, hand hygiene, safe surgery, handoff communication for you to use. And again, each of these tools will take you through that step-by-step process to really understand the process you're looking at, but more importantly, to really identify what your contributing factors are, what your root causes are, and then it'll give you the solutions that have been targeted and validated to those contributing factors, root causes. The other thing I did want to mention, again, it is confidential. We have a firewall between the center and the Joint Commission accreditation side. We always get asked that question. So our surveyors do not have any access to your project work or any of the data that you have entered. The only way that they're going to know about that you're actually using the Targeted Solutions tool is if you actually tell them that you're using it. And again, that might be very helpful, especially if they talk to you about some of the performance improvement standards. I did want to mention there are no standards right now requiring you to use the Targeted Solutions tool. It is completely voluntary. We do always ask that, if you've gone through it and you've been successful or even not successful, they'll give us feedback. Let us know in terms of how we can improve the tool, what worked and what didn't work for you. So again, at this time now, I just want to, say thank you for your time today as we went through the work of the center, the solutions development, the different targeted solutions tool we have available, but more importantly, the preventing falls tool as far as the project itself. So hopefully you've gotten a better understanding of that project work, as well as the targeted solutions tool that was created that is available for use today for all our Joint Commission accredited organizations. So again, thank you for your time. I just want to mention I'll also have Ann Kilpatrick with me here from the center. She's actually worked with several healthcare organizations who have been using the Prevented Falls TST, so she's kind of facilitated a lot of those discussions. So at this time, we would be happy to answer any questions you have about the project work or the targeted solutions tool that we have available for you with regards to preventing falls.
The conference has been unmuted.
Hi, this is Lynn. I have a couple of questions. I totally agree with you that the causes of falls can differ from unit to unit, but I'm wondering about collecting data on all falls for an organization versus just a pilot unit. We have someplace between 10 and 15 falls per month in the entire organization. So if we only did the falls on one pilot unit, it seems like it would take a long time to have data that would be worth analyzing. How do you balance those two out?
So again, we leave it up to the organization. I mean, each organization is going to know as far as where they're going to see the biggest benefit. So if your biggest benefit is to roll out this project for the entire organization, we would recommend that, yes, you can go that route. You know, one of the things you just have to keep in the back of your mind is in terms of all the resources that you'll have to have dedicated, the folks that will be trained. But if that's something that can be accomplished, again, you don't have to limit yourself that you only have to do it on one or two pilot units. You can roll it out completely to the entire organization.
And Lynn, this is Ann Kilpatrick, and many of our hospitals don't even have 30 falls a year. So if you have a unit or two that you are concerned might not hit an adequate baseline number of between 20 and 30 falls, you can combine some units that are similar and run your project that way between two similar units if you can. And it's not absolutely required that you have 20 to 30 falls, of course, because you'll still learn what your top contributing factors are. And you can get to 0 falls maybe quicker or sooner than anyone else.
Does it make sense to combine, say, like units, all the medical units or all the surgical units or all the critical care units or something?
It makes sense on paper, but again, that would be an individual facility's decision to see what you think. Like if you have an ortho and a neuro that are pretty similar with maybe they even float staff back and forth, that would certainly make sense. Yeah, so it's up to you all to decide what makes sense for your organization, because one of the most important things to staff is that they believe that they're using their own data to make decisions.
Yeah, totally.
Yes, absolutely. Thank you.
And one thing I wanted to add on to your question, Lynn, and for the group, the nice thing about the tool, as I mentioned earlier, is once you start entering data, it's going to do that analysis for you. So if your decision is to go organization-wide, that's great. If your decision is, you know what, we're going to take a unit-by-unit approach, if you then set up your projects, you can still also aggregate that at an organizational level. So that's the one nice thing about the tool is you can actually look at the data at a unit level if you set it up that way as unit projects, but you can then also still aggregate it at an organization level as well. The other thing is if you're part of a system, that's something we can work with your system liaisons where they can, if you are willing as the single organization to grant them access at the system level, once the system level has access to all the organizations underneath, they actually then can also aggregate the data then at a system level. So there's a lot that can be done with the data as far as sorting it, looking at it, taking a different approach to it. So again, I just wanted to let everybody know that.
Great. Thank you very much.
Hi, this is Terry. I have a question.
Yes, Terry, go ahead.
Thank you. We have a Falls committee here and representatives from each unit. So I'm wondering about how long is the training time for each individual member to be able to use this tool effectively?
Hi, this is Ann again. And what I would recommend is that after looking through the tool and getting a good feel for how to navigate it, the measure section is where the great training materials are. And we recommend that every RN on a unit where a project is going to be conducted go through the training, because we highly recommend that the nurse taking care of the patient fill out the data collection form or enter it into the computer, whichever way you decide. But there's a 9.5-minute training video, and then there's a wonderful data collection guide that you can download or print off and have handy on those units where the project is being conducted. But so the training itself, I would say, would be less than an hour, and that includes studying the training guide and taking the exam.
Oh, great. Thank you very much.
Yeah.
Absolutely.
And Terry, one thing, I wouldn't take a different approach in terms of training your folks. You know, however you train them now, you could take that similar approach to roll out as far as the training for the preventing falls. If something works very well for you with getting staff trained, I would use that approach.
Okay. Thank you.
Any other questions?
I do have one more question. Could you talk a little bit about some of the causes that have been identified and that you've developed solutions for?
Sure, and I'll actually pull that up as well here. So we have everything, and we also have it split up by categories as well, but you can see some of the things that were looked at was in terms of bathroom-related toileting, you know, patient fell while toileting, medications that increase the risk, so you're looking at that. Call light, which we see very often. Fall risk assessment is one that's actually very interesting because many times when we talk to the organization, and Ann could jump in from her standpoint, but from my perspective working with the organizations, they don't always see this as a contributing factor because they'll tell us, well, we have a fall risk assessment. But when they start to really look at it, the fall risk assessment, they'll start to see there's inconsistencies with that tool of how it's being implemented, how it's being used by staff. Some of it is due to education. So again, if it's not consistently being implemented by staff or used like it's supposed to, then of course you're not going to get very accurate results from that fall risk assessment. So when they start to take a deeper dive, although every organization I've worked with and talked through with regards to this project, they always say they have a fall risk assessment. It's when they really start to look at the compliance and the usage of it where they then start to see why that is a contributing factor. The other piece is the handoff communication piece I've seen often as well in terms of there's certain things that aren't communicated back and forth with that patient, whether it's a new medication that they're on, certain things are happening that all of a sudden now that fall has occurred. So these are some of the common ones that we've seen. Ann, anything from your perspective?
Yeah, absolutely, and thanks, Klaus, for bringing up the handoff communication. That and the falls risk assessment are part of the core solutions we recommend that you take a look at and audit. But for handoff communication, for instance, we heard a lot of nursing units report that when physical therapy brings a patient back to their bed, they may forget to connect the call light, they may forget to connect the bed alarms, and they may forget to notify the nurse that the patient's in bed. and the patient gets up and falls. So that's a real good example of handoff communication.
Mm-hmm.
But there are 13 main topics that we found with multiple contributing factors within each of those 13. And that you'll find that the data collection guide, the form, is very granular.
Mm-hmm.
And I have heard from staff nurses that have been trained and then started filling it out that this is good information that we can use, and it also makes me start thinking about falls in a different way, which is huge.
Hi, I have a question, please. This is Juanita.
Yes.
Contributing factors, we've delved into that repeatedly, but are you saying the recommendation is that if you do this, follow what you just said, you wouldn't have to constantly circle back to try to improve things? Because due to attrition, et cetera, and all that stuff, turnover on a unit or what have you, things seem to fall off, and then you have to come back and you're doing the same thing over again 6 months, a year, 2 years later.
And that's a great question, and again, that's something that we've heard throughout working with our organization has been that piece of it that you have mentioned. You know, we've seen improvements made from the solutions we've implemented, but we haven't been able to sustain it, whether it's attrition, again, new employees coming in,
Correct.
leadership within that area moving. So that's why it's so critical, and that's why there's such a huge focus on what we call that control phase. It's to
Correct.
really build that piece of it, the plan itself, the monitoring piece of it, because that's one of the things that we see as one of the factors for why things aren't sustained or controlled is there isn't that continuous monitoring occurring. And that is really so critical, because once you start to see something trend negatively, the quicker you investigate it, the easier it is for you to identify what the issue is, that contributing factor, and then be able to solve it, and again, be able then to sustain those fall rates and the fall with injury rates, those low ones that you have achieved through.
So as a follow-up to that then, would you recommend then placing like that control plan, or after each root cause has been identified or, you know, that trigger, that you place it on that specific unit just to keep people in tune? I mean, like,
yeah, I mean, so that's part of the control plan is, and you'll see it populate once you've identified what your root cause is and you've implemented the solution. That solution at root cause are part of the control plan. So again, this is going to be something that you're going to be monitoring moving forward.
At least no one stopped and asked me for directions, so.
So, any other questions?
What do you do
Thoughts?
again? Let me follow up to that one more time.
Sure.
So continuous monitoring. I know that sometimes you might monitor, and if things seem to look great, that tends to fall off. So what is your recommendation for if you have it, quote unquote, under control, so you would not be monitoring or meeting, let's say, monthly or what have you? What do you suggest? What time period to circle back to make sure? As
far as that, it isn't a time period, because you want to continually monitor the process. So again, you're using the measurement tool for every fall that occurs. So you want to build that in as part of your process, of your control process. So again, the important thing here is going to be actually that the process owner itself is actually looking then at that analysis. And the nice thing, as I mentioned, is as you're collecting this information for each of the falls continuously, it's going to do that analysis within the targeted solutions tool, which is then available. So part of that process is going to be for the process owner to actually look at that data of what's occurring. And that's something that should be continuously done, because that really gets you to sustaining improvement. It's not something that you can put a time frame on. You know, we'll look at it quarterly. We'll look at it every 6 months, because at that point in time, there has been so many things that have occurred in your environment, and more importantly, if you want to go back to staff and ask them any questions about that fall, it's going to be very hard for them to collect anything on that. So again, that's really the importance of sustainability, is for you to be able to investigate as quickly as possible once something starts to go wrong. And again, if you're collecting all that false data, you're going to be able to see that.
That makes sense. Thank you.
Any other questions? All right then. Well, thank you very much.
Reminders, they